Students are sometimes confused by the distinction between prospective and retrospective cohort studies. The key distinction is really based on when the investigator conceives the study and begins to enroll subjects relative to when the health events of interest have occurred. But let's take a closer look at this. Both the retrospective and the prospective cohort study follow that of a fundamental cohort design. That is, they identify a cohort of individuals or group of individuals who initially do not have the outcome of interest. The cohort is then grouped based on their exposure status, and exposed and non-exposed individuals are then followed forward in time to see what subsequently happened to them, so we can compare incidents and look for associations. First, let's take a look at the prospective design. We're going to, as an example, look at the Nurses' Health Study, which was a prospective cohort study that was begun in 1980. These investigators wanted to understand more about the determinants of heart disease and cancer in women. And they decided to follow female nurses because they offered many advantages in terms of long-term follow-up. So they began to enroll nurses, and they had the advantage here that they could verify that in fact they didn't have any of the health outcomes of interest, and they could begin to very carefully assess their baseline exposure status with respect to many possible exposures. And when they had finished their enrollment period, they in fact had identified a cohort of 117,000 nurses who were known to be without cancer or cardiovascular disease. And they could then begin to follow this cohort forward in time, checking with them periodically every year or 2 years, administering additional follow-up questionnaires that would ascertain any changes in their exposure status, and also identify health events, health outcomes that were of interest to the investigators. After some time had elapsed and health outcomes had begun to accrue, they could then begin to test hypotheses. So, for example, they could take their cohort and they could group them according to body mass index and perhaps compare obese and lean women to see if obesity was associated with an increased risk of heart attack. But in addition to looking at this particular exposure, after time, the investigators had the possibility of actually testing many hypotheses, answering many questions about a whole variety of other exposures, looking at, for example, nutritional habits, exercise, and so forth. And the key thing here is that this study was pre-planned and pre-designed to answer specific questions. They had the ability to verify that the subjects they enrolled, in fact, were free of the outcomes of interest at the beginning, and they could assess their baseline exposure status with respect to many exposures at the very beginning of the study before any of the individuals had developed any of the outcomes. So this has the possibility to greatly reduce misclassification bias. And by collecting information on many exposures at the beginning, it also gives them the opportunity later on to control for confounding factors. Now let's contrast this with a retrospective cohort study. Here our investigator wants to determine whether chemicals used in tire manufacturing increase the risk of death. He's dealing with a very rare exposure, relatively rare exposure, and he decides to jump back in time to identify his cohort. He knows of a tire manufacturing company that has been in operation for several decades, so he jumps back in time to study this cohort. Obviously, at the point in time at which he goes back to identify these subjects, none of them have the outcome of interest, but in the interim, some of these individuals have in fact died. So some of the health events of interest have already occurred by the time the investigator conceives and initiates this study. Nevertheless, jumping back several decades, he's able to identify the employees, and here, though, he has to use their employee health records as his primary source of data. This would be expected to be probably a good source of data in order to determine whether they had the exposures of interest or not. So, for example, individuals who were directly involved with the manufacture of tires who would have been exposed to the chemicals were clearly identified, and other employees of the company who were perhaps administrative or sales force people would serve as a non-exposed comparison group. Having identified these two groups, one could then see what subsequently happened to them. And here, of course, the outcome of interest is death, and we could use the employee records and perhaps the National Death Index and other sources of information to ascertain whether or not these individuals subsequently died. But notice that these outcomes of interest have all occurred prior to the investigator initiating the study. The other problem with this study is that the study was not pre-planned. The data that they were using was based on the employee health records, which were clearly not designed to answer a scientific study. They would have had many omissions, and this would have made it difficult for the study. There likely would have been some misclassification of various status, and there would have been a lot of missing information with regard to many other exposures that could be confounding variables. So this has a lot of disadvantages compared to the prospective design. So this cartoon kind of summarizes the key difference between these two. In the retrospective design, the investigator jumps back in time to identify the disease-free cohort and then looks at what subsequently happened to them. But the health events of interest have occurred prior to the initiation of the study. In contrast, in the prospective design, the study is pre-planned. The investigator can enroll individuals who are clearly demonstrated to be disease-free or do not have the health outcomes of interest initially, and he can very carefully design data collection instruments that will allow him to assess their many baseline exposures prior to anybody developing any of the outcomes of interest. And this offers very distinct advantages in terms of minimizing bias and also providing better control of confounding.